calling the quality and compliance meeting starting at 3:07. And Anita, you have a roll call for us?
I've noted that.
Okay, great. Can I get an approval for the agenda? Okay, Lisa makes a motion. Can I get a second? And I still, is there anybody online for public participation? Okay, and I see no one here, so we will move on. And I need to get approval for both the December and the January minutes. A motion for approval, please. Motion. No second. And now we can move on to old business. Gail, the compliance work plan, please.
All right, thank you. Okay, I put in for a review for the committee members, the 2024 compliance work plan. This will be updated once we complete the 2025 compliance risk assessment. But just wanted to show where we are at with our 2024 ending of the compliance work plan. Just to note, I will be meeting with the chair, working on our annual board compliance training at a station. We do have training this section, but we'll be working on our training, so that I marked as red on this plan because we don't have a training plan set for this year. And then I think that was the one thing that I really highlighted that we need to work on moving forward. If there's any questions on that.
Questions? Anybody have questions? And I'm going to go ahead and stop us ahead and do introductions because we have a new member here, person. So I'm Shelley, I'm the chair of the committee, obviously, and I've been on the board for 2 years now.
I'm Beth Mal. I've worked here for, I don't know, almost 10 years, I guess, as the contracts manager, and I am transitioning to the risk manager.
Great. Yep, I'll let you go ahead.
Dr. Johnston, I've been on the board. This is my 7th year that I'm in. And welcome to this group.
I work with Beth every day.
Yeah.
I'm Hal Geiger. I'm the board, but I'm not on this committee, but I was on it last year, so it's near to my heart.
I am Lisa Peterson, and I've been on the board for almost 3 years, and I've been on the quality committee for most of it.
Nice to meet y'all.
Okay, let's go ahead and move on to the 2024 board compliance metrics.
All right. And I will say that Beth does a lot of these metrics behind the scenes and has done it for years. So you may not have put a face to a lot of the work that she's done. So the metrics, as you can see, finished year to date. Put in some of the things that we are finishing up. Code of conduct was sent out.
What page are you on?
I am on page 11 of 97. There you go. Here. Yes. So as we finished up our end of year training with our employees, because most of our training is done on an annual basis, you'll see we're almost finished. Our directors are just finishing up, getting the last few people to finish up their training. Exclusion screening, that is something that actually Beth does. We are good to go there. Our monitoring, we're doing good. Not Beth. Tammy and Rachel and I have a good plan moving forward. In 2025, we're increasing our internal auditing for that we're going to be doing, and we should be able to have a better auditing program for our auditing committee for our charts that we're doing. So I'm looking to increase that for 2025. So this is just a FYI tracking of what we need to know, and I'll be talking a little bit more about the plan for a dashboard moving forward when we do our training.
Thank you. Moving on to new business. Robert, can you tell us about the CMS Care Compare review, please?
Yes. I'm still looking here. Okay. Let me wait till that slide comes up. There we go. Hi, I'm Robert from Quality, and I'm going to present our April 2025 overall star rating report card. And just for some context before we get into it, this is information that will be publicly available on CMS's Care Compare website sometime in April of this year. And I'm just going to read a paragraph directly from CMS that speaks to this, and it is that the overall star rating is based on a hospital's performance compared across all hospitals in the nation. The overall star rating is meant to capture a hospital's performance as a snapshot in time and should not be trended over multiple years. Shifts in the hospital's overall star rating are expected as measures are added, removed, and/or updated, and as data periods for various measures are refreshed. Summary score ranges will also change from release to release due to the underlying distribution of hospital data as performance on the measures across all hospitals evolves over time. So this is our performance compared to all other hospitals that are eligible to receive a star rating. Last time that this was refreshed, we had 4 stars, but as you can see, our current overall star rating is now at 5 stars. The national average is 3 stars. So achieving a 5-star quality rating is a big deal. And I just want to give you a couple statistics to help illustrate that. So in this particular reporting period, there were 4,609 hospitals that reported information to CMS via the Care Compare. Of those, only 2,891 were eligible to receive a star rating. So in the other group, there were critical access. They chose not to report, things like that. A lot of our competitors fall into that category locally. But of the 2,891 that were eligible, only 10%, well, actually it's 10.1% achieved the 5-star quality rating. So we are one of 291 hospitals in the nation to achieve this level.
Congratulations, Jay.
Now, the methodology that CMS uses to calculate the star rating is it's a 7-step process. So they select and standardize the measures that are going to be used for the star rating. They assign the measures into measure groups. They calculate and standardize the measure group scores. And then they calculate the hospital's summary scores as weighted averages of available group scores. After that, the application of minimum thresholds for receiving an overall star rating, which is at least 3 measures in at least 3 of the measure groups, one of which must be safety of care or the mortality group. And then the hospitals are assigned to peer groups based on the number of measure groups with at least 3 measures. So of the hospitals that are eligible, you have a peer group for 3, a peer group for 4, and a peer group for 5. Peer group 5 is where we are. That's the peer group we are in. Now, the peers data is unknown to us. We can't see it at this stage. We can only see it once it's publicly available, like any consumer would. Finally, they use what they call a clustering algorithm to categorize the summary scores into the star rating. And the measure groups, as you can scroll through there, we have our mortality measures, our readmission measures. You can see our hospital's result, the measure performance category, which is how we compare basically to the national mean. In some cases, it's going to be say the same. Some cases it may say better. Some cases it may say worse. It may say NA if we didn't have data. Or as you go down, you'll see dash dash, and that means that they don't, in that particular category, they don't use the measure performance. As you scroll down there, you'll see our HCAHPS, our patient experience, timely and effective care. And that is the end. Now, again, this is a snapshot of historical data. It's not really very useful in predicting what you should be looking at or what we should be focusing on. What we're trying to do there is that information is going to be more real-time, more current, at least quarterly data, and we're using our new board quality dashboard for that, along with our A3 process. Gail, do you have anything you wanted to add?
No, I'm just gonna open it up to, are there any questions by board members? I knew Hal.
Well, I'm just curious. So this is from data that was reported in October of last year, if I understand this.
No, this
Yes.
is actually 2023 data.
Right, but it's what they call the October on that first slide. It is the October, what they call the October refresh. But Gail's correct. The data, the measuring periods, as you can see in the little categories, it'll say a lot of them are 2023 data.
And my question is, has Bartlett had a 5-star rating before, and when was that? Do we know?
I know the answer is yes, but I do not know the time frame.
Yes, we had a 5-star rating. It was 4 years ago. We held it 4 or 5 years ago. Or right at the start of COVID.
So,
Oh, I know what you're gonna ask me. Go ahead and I can answer.
okay. And how are we gonna maintain this? Because you've done such a great job.
You
Well,
want me to-
Can I
or you-
speak to that, Gail, just for a second?
Go for it, Robert.
The issue is it depends not only on our performance, but our peers or other hospitals in the United States performance. So as that's unpredictable, and we should hold this rating. I believe this is refreshed on an annual basis, but the issue is, like, for example, SEP1 on the screen there is something we're working on. We know we are below the national average on that. So the way to maintain is to work on the areas where we underperform. But we're not going to know what the peer data is going to look like.
Through the chair.
Yes.
I agree exactly what Robert's saying. So that's the one thing that we're talking about is anywhere that we are underperforming or are at the national average, we should be looking at coming up with a lean A3 process to improve our scores. So we know that's the low hanging fruit for us. And how can we do those? Some of the measures are the ones that we can't look at that are more abstracted from, like, our MIs or some of the things that we are not going to be able to fix, but like sepsis, right now the board gets a lot of information on how well we're doing at sepsis. And that's something we can work on because a person comes in that we identify as sepsis. There are certain things that we need to document in the care. And right now we are below the national average and we could do better at that. We have control over that. So identifying those issues and improving them is how we're going to help ourselves be part of that 5 group.
It's kind of a challenge to be working 2 years ago, right? So,
Of our 24 data is already it's going to be mixed. So we're working on our for next year.
well, again, great, kudos. It's pretty exciting. Any other feedback, questions from the committee? Okay, let's go ahead and move on to the HIPAA privacy report. Rachel, please.
Yep, I'm Rachel. I'm the HIPAA privacy officer. We utilize a product called Fair Warning that takes our policies of don't look at your coworkers' records or don't look at your neighbor's records or that type of thing. And obviously not to look at anybody's records that you're not involved in those cares. And we did not have any investigations last month. Actually, we haven't had a full-on investigation since October. So I think that that's doing really well, and everyone's becoming more cognizant of what's accessible and what's not. And with that, we do have a platform that offers training that I'm working with Gail and Chris Cairns with to get some education out there. And they're just little short videos that we can assign to the staff. I don't want to do overload because we do have regular training, but we're looking at the best way to do that. So that's in the works for this year. We also are auditing every inpatient observation, ER infusion, and same-day surgery chart, looking for gaps, consents, making sure the documentation is done, and we do that continuously and always have. So that's ongoing as well. Boy, I think that's all I had.
Okay. Thank you, Rachel. Are there any questions or comments from the committee? Okay, moving on. HIPAA Security Officer report, Chris.
Hi, I'm Chris Behrens, Director of IS. So our cybersecurity landscape is several products all working in unison to provide the security that we have. We have edge security at the network perimeter, where we have firewalls that intercept all data coming in and out of the environment. And they actually have a thing called deep packet inspection, so they can look for encrypted malware that's present within some of that stuff. We also have segmented network called a DMZ, demilitarized zone, where some of our applications live, and the data that comes into that zone it's treated differently than internal traffic. So these are public facing applications like Citrix or the patient portal. And the idea being that if there was any sort of like compromise to that, we would easily be able to shut that off. So it's just an extra layer of security there. We are also sort of lightly pen tested using two tools called Nessus and Nmap by the multi-state information, what is it called? Information Sharing and Analysis Center, which is a subsidiary of the Center for Internet Security. Happy to report that we used to have, so basically they publicly will ping different assets within our environment just to see what they can, what they can find out about our environment, or if they can breach our environment. And then they send us a report weekly on how that looks. We used to have some vulnerabilities that would show up. For example, we had a PowerScribe server that was, the intention of it was to allow providers to dictate on their phone, and that would then be ingested into our PowerScribe environment. And that always presented some problems. We also used to have an on-prem email server, and that had some vulnerabilities, and we have since somehow in the last 12 months cleaned up all of them. So it's an empty report. So right now, which is great. We also have what they call Microsoft Data Loss Prevention Policy, which prevents auto forwarding out of our domain. So if you've got an email account, you can't set up a thing where anytime I get an email, it leaves our environment. That's a really common tactic of hackers if they were to compromise an account. And of course, there's potential HIPAA information in any email. We also have some at the licensing level that we are currently at. Microsoft can scan the email and look for indications of patient information, any protected HIPAA sort of information, diagnostic codes, patient names, and that sort of thing, and it will automatically encrypt that email as it leaves our environment, based upon whether or not it meets those requirements. We are about to embark on a Microsoft licensing uplift that will allow additional functionality in this arena. So right now, Word documents, data at rest, we do have the capacity to encrypt those if they contain HIPAA information, but it's kind of reliant on the end user to mark, hey, I want this to live in an encrypted state. Once we achieve this licensing uplift, there will be some artificial intelligence that can be applied to the documents and can automatically encrypt them at rest. We have settings within the Microsoft O365 ecosystem that prevent external access to our SharePoints, so that there's no concern that if we are storing HIPAA protected information in the cloud, that they'll accidentally leave our environment. We have prohibited the ability for non-business accounts to chat with us through Teams. That's the new frontier, by the way, for everybody. First it was like calls while you were eating dinner, and then everybody got rid of their landlines, and then it was SMS texts from like click this link, and the new thing is chatting you through Teams. So we don't allow just anybody to chat. And then we have O365 cloud policy, which disables malicious macros. We have recently ratified an MFA policy and a remote access policy, which requires all cloud authentications for Bartlett resources from Bartlett identities to have multi-factor authentication, which is either a hardware token that gives you some one-time number that you have to type in, or an app that lives on your phone that gives another layer of security, ensuring that the person accessing the information is someone who should. And we have in that policy, we are having full adoption of multi-factor authentication within 90 days. We are currently at 45%. There are conditional access policies on those same cloud authentications, which reserve access to our resources, our cloud resources, to only in the continental United States. And then we have different filtering, DNS filtering. So you type in google.com, that resolves to an IP address. We can actually sever that lookup based upon reputation of what you're trying to get to, or indication of compromise. And then finally, we're about to go live on a system that will tie, it's called Cisco ISE or ICE. And that will tie traffic to identity. So in the event of a compromise, we can know exactly what traffic is and where it's originating, and be able to disable just that thread of traffic, sever that thread without having to shut off whole areas of operation that may have business impact. We have some third-party partners. Rapid7 is a intrusion detection and vulnerability management security operations center that's 24/7. They look for indications of compromise, and they'll call us if there's anything suspicious going on. We use a product called Cybereason for antivirus. Both of those are agents that are installed on all of our endpoints. We manage our browsers through Google Cloud Platform. And then we, and this is a HIPAA security requirement, send out annual training for a product called KnowBe4. Most of those things I've just mentioned are all going to be aggregated in the next fiscal year under Microsoft. So we're going all in on Microsoft in addition to those data classification advantages that I mentioned previously. There's going to be enhanced analytics because they're all under the same platform. They're all going to have like a single pane of glass that'll just give us a whole lot more ability to respond to things. In terms of the security risk audit, it was completed in December of last year. And to summarize, where we have to work, what I think the takeaways are, is that we need to review procedures. We've got decent policies. They could certainly be updated, and we are in the process of updating a lot of them. But where we are lacking is in documentation and standard operating procedure policy. Things like noting that we have decommissioned a certain computer. We observe a HIPAA security policy, but there isn't like a paper trail that I think is sufficient. So we're working on that as a department. And then we have a lot of people, a lot of community partners that have some remote access to our electronic health record that may or may not need direct access. So this is something I've been talking to Rachel Stark about, but we intend to do a pretty comprehensive audit of everybody who has what they call access to services within our EHR. And, you know, obviously, the less people, the less points of entry you have, the smaller the threat landscape is and the more secure everything. So those are just some focus areas that we have.
Well, I know data security is hugely. I'm not quite. Glad you're there doing it. Yeah, probably not a good idea. Any questions, comments from the committee? Okay, great. Back to you, Gail. Officer report.
All right. Well, I have a few things, some of them, first thing I want to talk about is we started up a new occurrence reporting system last year. And part of it, coming out of it, is it's easier to track compliance reports that came from staff to the compliance department. And the first page here talks about the reports that came out of it and where they went to. So last year we had 11 HIPAA reports that came from staff that got forwarded over to Rachel, our HIPAA privacy officer, to investigate and close out. We had 23 human resource concerns that forwarded over to our human resource department. And then we had 8 employee fair treatment concerns that also went to HR. We had 14 med staff rules and regs deficiencies. So these are things like missing H&Ps or other concerns like that that have to do with documentation and things with med staff. And then we had 27 appropriate of care concern reports that are things that I would investigate. And now that I have our risk manager, Beth, on, and she will be helping report. So that is our end of the year report for compliance reports that came through our current reporting system.
So a quick question. So now you'll be able to track same things year to year.
Yep. So now we'll be able to trend year to year where things are and be able to look at it and see if there's any concerns that we're looking at there. The next one is our first quarter, well, almost our first quarter patient grievances. So far this year, we've had 2 grievances come for our Bartlett Oncology Clinic, one related to quality of care pain management in the med-surg unit, one in our mental health unit, which I have just closed out, one in our emergency room that I've sent over for a peer review that's still ongoing. And then one related to patient rights, gender identity through PAS. And then I have actually 2 more that have come in since I did this in the last week. But both of those have been closed out. And then one thing that was a request by board members, and I'm glad, actually, I know Sarah Dodd is not on because she's running a clinic today, but Beth is actually knowledgeable on these. I know the board members were asking to have information on our physician contracts, since you have taken away the physician recruitment committee. So I actually have put in a list with Beth's help of which current physician contracts are out there. So these are all the contracts that we have now in place with physicians. And then I just have a list of some of the ongoing tasks that we're working on right now in compliance. Need it closer for you? Look at the 2 pages for your eyes. So any questions on that?
I don't have any questions. Al?
Yeah, back in the patient grievance, there was some kind of grievance in the emergency room, and that's undergoing peer review. Is that peer review done by somebody who's part of Juneau Emergency Medical Associates, or does it go outside of that group?
So the way it works, it goes to, Gemma actually has a contracted person who will look at it first, that I work with there, and I collaborate with them to look at it. And then they're actually, after that, they do a report back to me. And then if it needs to go further, then it goes to the Med Staff Quality Committee.
But the contracted person is part of Gemma, or?
It is part of Gemma. It's part of the Emergency Care Committee. And what they do is they do what is called a M&M committee, and they review it as a group, which in those meetings I go to, Kim sits in on, and the whole committee reviews the case as a group. And it's more of an educational and reviews the case. And if it comes out to be more of a physician care issue, then it would be excluded from that discussion and then go to MSQIC. So there's a process of determining whether it's a systems or other issue where you discuss it as a group or not.
MSQFC.
The Med Staff Quality Improvement Committee, and that committee that I'm on, and actually Joe sits in on those meetings when they discuss cases.
Thanks.
And that's pretty standard.
Yes.
Any other questions, comments?
Oh, I just have another comment. I just like the simplicity of this reporting. I mean, it's very efficient to go through this the way you have stated.
Good job, Gil. Okay, next thing is the compliance plan draft.
Okay, thank you, Madam Chair. On this, there is an action item that I will ask that if we can move it to the full board after we present this. So this is the Compliance and Ethics Program Management Plan. I apologize that I didn't have it fully ready in January for the other multitude of plans that you reviewed in January. So apologize for that. So this is the compliance plan. We are required as a healthcare entity and hospital to have one available for the hospital, since we get Medicare, Medicaid funds. Plan is pretty much straightforward to show what the hospital has in a plan, what the functions are. I know everyone had a chance to read it. I'm sure you read it with bated breath. It just shows what our steps are, what we're looking at. We are basically looking at fraud, waste, and abuse in our hospital. It talks about what our elements and metrics are, the 7 elements of a a good compliance program. We talk about the, our internal work plan areas. We talk about, having a code of conduct. We talk about having, oversight by the board. We talk about conflict of interest, something that the board has been very, involved in this year. We talk about education. We talk about audits that, we are very involved with the finance department doing our audits. We talk about making sure we're doing exit interviews with the HR on all of our employees. We also talk about making sure that we are updating our policies, procedures. Any questions that anyone had on the plan, or any typos that you found, Hal?
Okay, if there are no questions or comments, then this is an action item. And I think the suggested motion is up there.
Me to go for it, Lisa?
Yep.
Okay. I move the Quality and Compliance Committee of Bartlett Regional Hospital to approve the compliance plan and forward to the full board of directors of the Bartlett Regional Hospital for approval.
Approved. Alrighty. Gail, the compliance risk assessment.
Okay. All right, so sorry I got out the packet late. Anita told me that how I need to do better, and I will do better. Because I don't want to get Anita upset. So I thought, what did you think of it before I start?
I'm gonna be perfectly honest and just say it's a lot of material, right?
Yes. This is a lot of material. I'm actually thinking this is going to be put in the board ed packet, because this is actually came from my organization that I am part of as a compliance professional in healthcare. And I actually like this because this is the framework that I base our compliance plan off of, and I look at for developing our risk assessment that I'm working on. So I thought it would be a really good education to present to the board, because you're going to be seeing the risk assessment and the analysis of that coming forward. So that's why I thought it would be a good starting point for this year, because this is everything that we're building our risk assessment on. So sorry, it was a lot to digest and read, but it was also a good resource. So just to give you why I chose really basing our risk assessments and using this framework. This organization has been around since 1996. It has about 20,000 members. It's in over 100 countries. So it's a well-established framework. I looked at 2 different frameworks and assessed them. Sorry, Joe. I did an evaluation on both of them. And I thought it's really appropriate. They are very focused on healthcare. So when you look at the articles, if you really dive deep in it, you know, compliance, it can, if we don't do it right, it can cost us a lot of money as an organization. Most violations can affect individuals, and that's why we're here in healthcare. The person comes in the middle. I mean, Kim says it all the time, put the patient in the center. And that's what we need to do, because compliance, you have to put the patient in the center too. We look at, you know, what does compliance look at? You look at breaches of information, you look at theft of personal information, you look at product safety, you look at workplace safety, environmental, you look at OSHA, there's a lot of different things. You look at IT safety. There's so much information that compliance touches. I don't do it all. I have the team around me at the organization. Everyone has a little bit of compliance. So when you think compliance, you think, oh, it's gonna cost us money. Chuck's over there thinking about how much it costs. But one of the other things that it also costs is it could cost us our reputation as an organization. And our reputation is probably one of the most important things for us. Eventually, it's gonna cost money too if we lose our reputation. But that's the other thing we have to think. When you think, sorry, Anita, I just said, you're catching up. When you think compliance risk is something that is directly associated with a law or a regulation. So that's really what I'm focused in on is I'm looking at what laws, what regulations that are affected, but there's other things that are just guidelines or when you talk the ethics of compliance, some of it you just have to figure out what's the right thing to do. So that's what we're looking at for when we do our risk assessment. It's like, it's not an exact science. It's like healthcare. Nothing in healthcare is an exact science. I'm smiling at you, Hal, because you like exact science. You want the exact data. And unfortunately, compliance sometimes isn't the exact science. So that's what we look at. When we look at risk, a lot of this document talked about what is the board's appetite for risk. And that's a lot of what you guys are going to be doing tomorrow is you're going to be talking about your strategies. And I was looking over the documents for tomorrow's retreat. And it's like, what are you looking forward? What's your appetite? When we look at how many hospitals are on the brink of closure, you know, what is Bartlett's appetite for risk as we move forward and so forth? You know, that's when we look at risk assessments. You know, what is Bartlett's appetite for risk and where's our compliance for that, the board? So this is a really good document that talks about that. So that's why I was really thinking about what things I could give the board to think about on your experience and thinking about compliance as you look forward for training. The other thing I wanted to look at is in this document, and I don't, oh, Anita, I don't have the page that you need to go to. There is a figure, it's called figure 1.3. It was on page 6 of this document. This board member, yeah, keep going. At the end of it, yeah. Keep going. Maybe a couple more pages. One thing that.
One more page, I think.
Yep, there we go. One thing that the board has requested from me and the committee members last year have always talked about is how do we develop a dashboard for compliance that's meaningful? And in this document, I thought that the 20 principles that govern in figure 1.3 really gave a good structure for building out KPIs for compliance. Some of these KPIs I see should fit under other areas of the board. So when you look at governance and culture and strategy and objective settings, I look at, yes, planning and governance, but I think these 20 principles really look at high level board structure and how the board should be building their KPIs. And I felt that this was a really good structure for the board to start developing KPIs out for other dashboards. And this is one thing I wanted to discuss with Shelley and look at how do we build an effective dashboard out for the compliance committee, because I think that is one area that this committee has been struggling with. How do we get an effective dashboard? Cover and gather and present. So there is, and
What is the important?
and what is important and meaningful. And that's the one thing in this document when I think when you look at it and you break it down into your particular other committees, I think you'll find that there's KPIs that can be pulled out of this document that will lead you to the right KPIs, you know. Does everyone know what a KPI is? That's not at Bartlett. Key performance indicators, if you know. So that's something that we're bringing into our lean process. And I think that this shows high level that we can pull information from what we're doing and pull it up to the board. I know Joe is really working on a CEO dashboard that's bringing in information. And I think some of the information that we're doing through our lean process then would be able to roll up into things like this. So. Any questions, any discussion? I have a comment.
I really appreciate this. I know you and I have talked about this a lot, that risk management is more than compliance alone. You accurately defined for us what compliance is, but compliance is a subset of risk management. And I think that this will go a long way to educate the board on really what the risk management umbrella is, and administration can help us define where we're at and what our risks are, because that's been a little bit of a black hole, other than the conversations we've had about compliance over the years. The full umbrella of risk management has been a little bit of a black hole. Like a couple of the responses, anyone who's been here a while was CBJ takes care of it. They have a risk management officer. So I'm really glad to thank you and your group. Thank you for coming on to take the more high level holistic risk management look, and of course dashboards.
Looking forward to see sports that like you say are meaningful and actually give us good information to help us make decisions. Any other questions, comments for Dale? Okay, any committee comments or questions in general? I'm officially going to adjourn this meeting then. Thank you guys for all coming, and thank you, Gail and team, for the information today.
Thank you.
Thank you.
And I was going to try to reach out to see.
This was